Welcome back to our discussion of ace-promazine type compounds. This segment will discuss some of the important issues to consider when using them. There's a wide range of behavioral activity that's considered normal. Animals can be either in the midst of a fight or flight response or sleeping. Whatever the initial state, ace-promazine type compounds tend to inhibit the excitability of the animal, producing a more depressed state. If the animal is already excited, there will be less sedation than in animals that are either normal or already depressed by other drugs or by their injuries. When used as a sedative, respiration is not very depressed when compared to other sedative compounds. But increasing the dose does not produce a safe hypnosis or anesthesia without significant respiratory depression. So at anesthetic doses, ACE and other antipsychotics are very safe compounds compared to other sedatives. This is because of their high therapeutic ratio. Remember that the therapeutic ratio is the LD50 over the ED50. That is the lethal dose for 50% of the animals divided by the effective dose in 50% of animals. Because the lethal dose is so high compared to the sedative dose, a wide range of doses can be safely administered for sedation. In fact, the dose recommended on the bottle is often more than you need and can be decreased with little loss of sedative activity. One of the problems with these drugs is that they produce sedation, but any loud noise, bright light, or painful sensation can make the animal even more responsive than usual. So it's important to maintain a quiet, subdued exam and operating room. Major tranquilizers produce little or no skeletal muscle relaxation. If you're using the drug for standing surgery, this is an advantage because the animal can maintain a standing position without developing as much ataxia, that is wobbling, drunken-like movements, compared to other compounds. But if you're performing intra-abdominal surgery on a small animal, this might be a disadvantage as you may have inadequate intra-abdominal visualization. If good muscle relaxation is necessary for a procedure, benzodiazepines or barbiturate compounds might be better choices. While increasing the dose doesn't give you much additional sedation, it does start recruiting more cataleptic activity. Catalepsy is caused by an extrapyramidal Parkinson-like state where the motor activity is so disrupted that the individual is unable to maintain a normal posture and fluid movement. While increasing the dose doesn't give you much additional sedation, it does start recruiting more cataleptic activity. Catalepsy is caused by an extrapyramidal Parkinson-like state where the motor activity is so disrupted that the individual is unable to maintain a normal posture and fluid movement. They're also unable to initiate spontaneous motor activity. Parkinson patients have intentional tremors and trouble initiating actions because of a lack of sufficient dopamine. Generally, they also have trouble pivoting to turn in the opposite direction. Instead, they walk around corners, taking many little steps. Horses demonstrate catalepsy when they assume a sawhorse stance that makes it easier to balance while standing still. Catalepsy in mice and rats is marked by a tendency to not move at all, to not initiate new or exploratory behavior, as if hypnotized. When you slowly place their paws on a bar in the absence of external stimulation, they'll stay in place for several minutes. But loud noises or bright lights will break the trance. Remember that in spite of the sedation and catalepsy, these drugs are not very good anti-anxiety drugs compared to others, like benzodiazepines that block GABA aminobutyric acid receptors. Although drugs like acepromazine produce sedation, making animals appear less responsive to painful stimulation, they have, in fact, no analgesic activity by themselves. However, in spite of their total lack of analgesic activity, they do potentiate the analgesic effect of opioid compounds, that is, narcotic analgesics. This phenomenon is the rationale for the two combinations of narcotic analgesics and major tranquilizers that are marketed: Imobilon, a combination of etorphine and acepromazine, and Inovarvet, a combination of droperidol and fentanyl. These combinations provide excellent hypnosis or even light anesthesia and profound analgesia, whereas either ACE or droperidol alone would produce no analgesia. The antiemetic action of these drugs is best typified by the compound droperidol. Although many antiemetic compounds are available, droperidol is one of the most potent. It can prevent vomiting induced by digitalis, morphine, and other narcotic analgesics like apomorphine and even simple motion sickness. Because apomorphine is often used to induce emesis prior to surgery in an emergency situation in dogs, it's important to remember to use apomorphine first before injection of compounds like ACE. Otherwise, the emetic action of apomorphine will be blocked. However, ACE does not inhibit vomiting that's precipitated by local irritation of the GI tract, such as food poisoning. Adrenergic activity is not limited to the CNS. The peripheral nervous system is also impacted by adrenergic antagonists like ACE, and they produce cardiovascular effects. Throughout these lectures, we'll be using these two proportionalities to describe how drugs produce changes in blood pressure. Systolic blood pressure is affected most by how the heart pumps, as reflected in cardiac output and heart rate, because that reflects the maximum pressure that can be produced by each beat of the heart. Diastolic pressure is affected most by the degree of constriction of the vasculature, as reflected by the total peripheral resistance. The sympathetic nervous system provides some tonic activity to maintain adequate vasoconstriction of vascular smooth muscle to sustain a normal resting blood pressure. ACE-like compounds decrease blood pressure because they block the alpha-1 adrenergic receptors in the vasculature that maintain this tonic vasoconstriction, as reflected in the total peripheral resistance. As shown in this proportionality, they also decrease the magnitude and duration of cardiac action potentials, decreasing cardiac output by decreasing the heart rate. The combination of ACE plus local anesthetics that also decrease blood pressure by their paralysis of vascular smooth muscle makes that combination of drugs somewhat dangerous due to the profound hypotension that can result. ACE also decreases epinephrine-induced ventricular fibrillation that's often associated with the use of halogenated general anesthetics that stimulate epinephrine release from the adrenal. Finally, some drugs of this category have significant anticholinergic activity, reducing the amount of atropine-like compounds necessary in pre-anesthetic combinations. So now we know that these drugs can cause hypotension. Sometimes during a surgical procedure, the blood pressure decreases too much. It's important to remember that these drugs only antagonize alpha adrenergic receptors that induce vasoconstriction. They have no ability to block beta-2 adrenergic activity, the receptors responsible for vasodilatation. As a result, if you try to maintain blood pressure by injecting epinephrine, which has both alpha and beta adrenergic activity, only the beta receptors will be stimulated by the epinephrine, producing more vasodilatation, further decreasing blood pressure. The alpha receptors are blocked and relatively less accessible. This is referred to as epinephrine reversal. To avoid a precipitous decrease in blood pressure because of epinephrine reversal, use either norepinephrine or phenylephrine instead of epinephrine. This is because norepinephrine and phenylephrine are alpha adrenergic agonists with no beta-2 activity. So they can compete with the major tranquilizers for binding at alpha adrenergic receptors and eventually cause vasoconstriction and increase blood pressure. Compounds like ACE have a profound effect on temperature regulation. Although they can either decrease or increase body temperature, they're not classified strictly as either hypothermic or hyperthermic. Instead, they produce a response called poikilothermia, a situation where the body temperature tends to drift to the ambient temperature, whether that ambient temperature is higher or lower than the animal's original body temperature. For example, performing any type of manipulation in a hot barn on a warm day can easily increase the body temperature of animals. Similarly, placing a small animal on a cold surgical table might result in hypothermia even without drugs. Small animals are the most sensitive to this effect because they're even more susceptible to these temperature effects when treated with ACE or related compounds. You can use poikilothermia to your advantage in a situation of, for example, heat stroke, where you need to decrease body temperature rapidly by placing the animal in a cool environment. In this case, these drugs will help the animal lose body heat faster and cool down more rapidly. Acepromazine and its related compounds are not general anticonvulsants, in spite of the fact that they produce sedation. In fact, they can even facilitate seizures produced by compounds like organophosphate insecticides. Some people have traditionally claimed that these drugs enhance the susceptibility of epileptic animals to seizures as well, but this has been questioned lately. But even in normal, healthy animals, when major tranquilizers are injected rapidly, either intravenously or by an inadvertent intra-arterial injection, seizures might be precipitated because the drug reaches the brain too quickly to produce sedation and instead unmasks an underlying excitatory effect. To prevent this, always inject slowly after first checking to be sure that the needle is placed in the vein and not the artery. The color of the drug alone is yellowish and undergoes a distinctive color change in arterial compared to venous blood. In spite of the fact that major tranquilizers are not general anticonvulsants, they are good antagonists of a few specific convulsant compounds, namely nicotine, ketamine, and opioid analgesics. So if you use these drugs as anticonvulsants, be sure that the animal has either eaten cigarettes, tobacco, or been exposed to one of these specific drugs before attempting to stop the seizure. Drugs of the butyrylphenone category are very similar to those having a phenothiazine structure, like ACE. However, there are a few differences. Butyrylphenones have less anticholinergic activity and slightly less alpha adrenergic activity than phenothiazines. They also have greater extrapyramidal effects, so they're more likely to produce catalepsy, tremors, and rigidity. One clear advantage is that they have greater antiemetic activity, as typified by droperidol, a member of this class of drugs. They also produce less ataxia, that is, drunken-like movement, which is probably associated with their lower ability to block alpha adrenergic receptors in the reticular activating system. Butyrylphenones generally last longer than phenothiazines, allowing them to be administered less frequently, a clear advantage when sedation or antiemetic activity is the desired effect over several days. One final drug is reserpine. For centuries, it was widely used in Hindu medicine for the treatment of hypertension, insomnia, and insanity. This corresponds nicely with our current use of these drugs and their ability to produce hypotension, sedation, and antipsychotic activity using the phenothiazines and the butyrophenones. Reserpine's mechanism of action is very different than that of either the phenothiazines or butyrophenones, which tend to be simple alpha adrenergic receptor antagonists. In contrast, reserpine inhibits the uptake of biogenic amines like norepinephrine and dopamine and serotonin into their storage vesicles, leading to the catabolism of these biogenic amines in the cytoplasm rather than their storage in vesicles for reuse. Reserpine produces essentially a chemical sympathectomy. Because of the action of reserpine depends on a depletion of neurotransmitters, it has a slow onset of action, even when given intravenously. But once produced, the effect lasts for an extremely long time because the monoamines have to be resynthesized from their amino acid precursors. By destroying sympathetic nerves both centrally and peripherally, the body is left with an excessive parasympathetic tone. Sedation, for which it was previously used in racehorses, hypotension, and bradycardia, the basis for its use to prevent aortic rupture in turkey poults, but also effects like diarrhea, nausea, gastric ulcers, respiratory depression. This constellation of extreme parasympathetic actions doesn't lend itself to a widespread clinical use, except as an investigative tool to produce sympathectomies or as a model of depression. When using compounds related to ACE, be sure to take care when using them in animals with a history of seizure disorders. Because major tranquilizers are not general anticonvulsants, they should also not be used in situations where the cause of a seizure is not clear. Avoid these drugs after strychnine poisoning or tetanus toxicity, seizures that are typified by opisthotonus and catalepsy. They won't provide general anticonvulsant activity in these situations. Avoid the use of major tranquilizers in combination with large doses of local anesthetics because of the profound decrease in blood pressure, as well as the potential for convulsions. The last thing to note is that the withholding times for these compounds should be followed carefully prior to slaughter, as they remain in the tissues for a long period of time because of their strong protein binding. In summary, ACE-promycin produces little or no respiratory depression when compared to other compounds that produce an equivalent degree of sedation. It produces little or no hypnosis, so it's not used as sleeping pills per se. Because of the minimal skeletal muscle relaxation and ataxia, it can be used for standing surgery, but may not be adequate for intra-abdominal surgery. You should always remember that the phenothiazines by themselves have no analgesic activity. They only potentiate the analgesic effects of simultaneously administered opioid compounds, that is, narcotic analgesics. Antipsychotics also have no general anticonvulsant activity. And finally, they have no dependence liability, that is to say, withdrawal from long-term treatment with major tranquilizers is not typically associated with a classic withdrawal syndrome. However, as is true with all sedative compounds, tolerance to the sedative effect does develop over time, so higher doses may be required to produce sedation. In summary, compare the effects of major tranquilizers to those of barbiturates, minor tranquilizers, muscle relaxants, and derivatives of xylazine that are covered in separate videos. Take note of their similarities and their differences because those determine the situation in which they are or are not clinically useful.